air, oxygen if needed, fluids, fever control, right? If this is causing bronchospasm and they're having wheezing, you can also give them bronchodilators if they need it, right? And then there are some other medications. There's certain antiviral medications that can be helpful. Typically, they need to be given very early, so things like Tamiflu and whatnot. They can help interfere with viral replication, might help people, some people recover better. One thing you have to understand is viral infections, because they can cause inflammation and mucus accumulation, all that can increase. You can have an increased risk of bacterial pneumonia. And a lot of people that end up dying of influenza actually die because they develop a secondary bacterial pneumonia, because essentially the flu hits them, or the influenza-like illness kind of hits their lungs. Their respiratory system takes a hit, and that allows this bacterial infection, this bacterial pneumonia, to come in, and they end up dying of bacterial pneumonia. And every year, depending on the strain of flu, it can be more or less severe. Typically, populations who are immunocompromised, who are very young and very old, tend to be at, or have substantial comorbidities, tend to be at higher risk for the more life-threatening complications of influenza. Most people tend to do okay. Most people tend to recover okay. And influenza rarely is a systemic disease. That is to say that the virus leaves the respiratory system, goes into the blood, and goes to other areas of the body. And we call that a viremia. When someone is viremic, they've got virus in their blood, and the virus is going to other areas of the body. Influenza tends to stay within the respiratory system, and tends to be very specific to the respiratory system. All right, that's not necessarily the case with other kinds of viruses, specifically the next virus we're going to talk about, because it's, how can we not talk about it? And that is something called SARS CoV-2. All right. It stands for SARS. SARS is severe acute respiratory syndrome. CoV-2, coronavirus 2. So there are actually several different coronaviruses. There are about four to five coronaviruses that circulate every year. And they cause approximately 25 to 33, so approximately 1/4 to 1/3 of all cases of the cold, the common cold, right? So viral upper respiratory infections are actually caused by these 4 to 5 or so coronaviruses that just circulate every year. And you get infected with these so often, your immune system recognizes them. It's just like, been there, done that. Pump out some antibodies, cell-mediated response. Go ahead and take care of those infected cells, and in a few days you get over it. It's just some sniffles, no big deal, right? However, there are other coronaviruses that have not been circulating for hundreds and hundreds, perhaps thousands and thousands of years, and the immune system it has not been able to grapple with them as long, and we're not able to respond immunologically to them. The first one was called MERS. Well, the first syndrome, that's a Middle Eastern respiratory syndrome, came out of the 2000s, back in the 2000s, and that was SARS CoV-1. SARS coronavirus 1 caused MERS, and MERS is still out there. MERS tends to make people sick pretty quickly, and when it comes to viruses, when you get super sick really fast, you tend not to travel around, right? And so you tend you tend not to infect as many people because you're sick. You feel horrible and you're stuck at home and you don't want to go anywhere. And so you're not out and about spreading the virus around. But other viruses that don't make you super sick, well, what happens? I don't feel too bad. I have a stuffy nose. You get out and about and you spread the love around to everybody, right? And so typically, really nasty viral infections, like even some of the worst viral infections like, Ebola, Marburg, the viral hemorrhagic fevers, these people get super sick really quick and they tend to die fairly quickly. They're not out spreading it around. And so it's much harder for those kinds of viral infections to become pandemic, right? You get an epidemic. An epidemic is an outbreak. So you have an outbreak in a specific area of the world. And if that spreads to multiple continents, right? So the epidemic spreads to multiple continents, we call that a pandemic. And then if that virus then remains in the human population, never goes away, it's always there, and it continues to circulate every single year, like these 4 to 5 coronaviruses that cause a common cold, then we call that endemic. It's always there, it's always around, and the human immune system's like, yeah, I got this, don't worry about it, right? So SARS CoV-2 back in 2019 started out as an epidemic. We think in China. There's the evidence. There's some evidence that may even goes back a little further, but right now some of the best evidence we have is toward the end of 2019. We started seeing the first cases of this weird ILI. Initially it was an ILI, an influenza-like illness, because the patients looked a lot like they had a bad case of the flu. And there were, some clusters of cases, areas of China. And then very rapidly, within months of that, it became pandemic and spread to other countries, Europe, Southeast Asia, United States, right? And now it's really looking like SARS CoV-2. It really is. It's really looking like it's going to be endemic. We're not getting rid of SARS CoV-2. And probably within some dozens of years, maybe hundreds of years, eventually it will become yet another one of those circulating coronaviruses that causes a common cold, right? Obviously, we're not there yet, but eventually the trajectory suggests that it's going to be another one of those where everybody's been infected with it multiple times, and vaccinations, immune systems got a good handle on it, and it just becomes another case of the common cold, really. But right now we're kind of in this pandemic transitioning into endemic. That's kind of where we're at now. SARS CoV-2, or the disease that SARS CoV-2 causes, is COVID-19. Right, coronavirus disease 2019. The signs and symptoms are very similar to influenza, but the epidemiology is a little different. So the onset for COVID-19 is, so the OG COVID-19, or what we call the wild type variant, the Wuhan variant, that was initially identified back in 2019, because the current variant, the dominant variant we're dealing with, the so-called Delta variant, came out of India. Its behavior seems to be a little different than the wild type, or the OG Wuhan variant. But when we go back and we talk about influenza, right, the signs and symptoms tend to occur within about 1 to 2 days. So you get exposed to influenza, and if you get infected within about a day or two, you have a fairly rapid onset signs and symptoms. With COVID-19, the onset is much more delayed. than influenza. So you're looking at, 3 to maybe 5 or more days. With the Delta variant, it's closer to 3. So the onset seems to be a little faster, as far as I can tell. But the onset is a little prolonged with COVID-19. And the duration is very different. With influenza, you get sick, and within about a week, you're getting better. With COVID-19, in some people, they do recover very rapidly, say within a week. There are other people that their immune system may respond, and the immune response, the immune system may actually cause more damage. Remember, in pathophysiology, we talked about all the things that happen if you have too much inflammation, and you've got cytokine storm, and you've got, right, all these reactive oxygen species being produced, and all these chemokines, and these white blood cells activating. And that sustained inflammation can actually be damaging. And so some people that get COVID-19, what happens is they have essentially an overreaction of their immune system that damages their lungs really severely. And so what you can see with COVID-19 is that first week is a lot like flu. It's really similar to flu. And then what happens in the second week is they get this inflammatory syndrome, and they start getting worse, and they get hypoxic, and they're having trouble with their oxygen levels, and they get worse. And so they tend to, they may do okay for a week, and looks like they're doing okay. Kind of looks like the flu. And then the second week they deteriorate. So that's very different from influenza, where, if you typically get over it within a week or so, unless you get like a secondary bacterial infection, pneumonia, but that's easy enough to see and potentially treatable with the right antibiotics. The other thing that we see with COVID-19 that is very different from influenza is you can get a viremia. The way that the SARS CoV-2 works is there's a protein in its capsule called the spike protein, or the S protein. And I think you all probably have heard of this. How can you not if you watch any news? And essentially that spike protein, what it does is, unlike influenza, which interacts with salicylic acid, or sialic acid, excuse me, the spike protein interacts with another molecule in the cell called ACE2. So it actually attaches to a receptor, angiotensin converting enzyme receptor 2. And you should be familiar with ACE, because we that's an important signaling pathway when it comes to causing vasoconstriction and dilation, right? And so it attaches to the ACE2 receptor. And then what happens is the spike protein, when it attaches, it undergoes a conformational change. It kind of like elongates and twists. And it undergoes something called fusion. So the spike protein attaches, it elongates and twists, and that allows the virus to fuse with your cell and then dump its RNA into the cell. And then that RNA goes on to the messenger RNA goes into the ribosomes of the cell. And the ribosomes crank out proteins, the proteins self-assemble, the virus assembles, and then it buds out of the infected cell and propagates the infection. Well, unfortunately, many different cell types in your body have this ACE2 receptor. And so the SARS-CoV-2 virus does not necessarily stay isolated to the respiratory system. It can go throughout your body, and it can go into other organs, and it can cause problems with the heart, problems with the brain and other organs. In fact, it can actually cause problems with the very lining of your blood vessels, and it can cause blood clots. So people can die of pulmonary embolisms and things like that with COVID-19. So COVID-19 kind of starts off, the signs and symptoms are similar to influenza, but in some patients, in a minority of patients, might I add, they can have these other weird kinds of things due to the biology of the SARS coronavirus 2, which is very different from the biology of influenza. All right. Are there any questions over that stuff there? Anybody have any questions? Okay. So as far as treating COVID-19 is very similar to influenza for our purposes, good supportive care. These patients are going to be at high risk for like blood clots and clotting disorders. They're going to be at high risk for the inflammatory response, right? So they're going to be at higher risk for ARDS and things like that. And we may have to manage them with ARDS. There are some therapies that seem to show benefit. There are some antiviral therapies that, if given very early on, can, in some people, prevent COVID-19 from progressing. So if you can get to them in that first few days of their infection, you can give them monoclonal antibodies. In high risk people, you can kind of prevent, in some number of them, prevent them from deteriorating in that second week. Because by the time you're in that second week with COVID-19, you really don't have a whole lot of virus. Your immune system, you've taken care of the virus, right? The virus is on the way out. It's really now it's the overactive immune system. And so that's why steroids have also been shown to be very beneficial and to help reduce the amount of death and disability. And that's why we don't give steroids right away. Somebody has COVID-19, they don't get steroids in the first week. They'll get steroids in the second week if they start going into that early inflammatory phase. So you would give antivirals in the first week, right? Things like monoclonals seem to be the best antiviral therapy. There are many other proposed antiviral therapies, but there's no evidence really, or mixed evidence at best, that some of these other therapies have any benefit. So things like chloroquine, hydroxychloroquine, ivermectin, convalescent plasma, those things, there really is no evidence that those are beneficial. But monoclonals, there's some evidence there. What's the idea behind ivermectin use? So as far as I know, there has been no proposed mechanism for how ivermectin would have any efficacy in treating COVID-19. So ivermectin is actually an anti-parasitic agent. It treats certain parasitic worms, lice, things like that. It's actually a super important drug, like world-changing, right? This has fundamentally changed the lives of millions, if not billions, of people around the world, right? Where, you know, they suffer from these various parasitic infections. And essentially what ivermectin does, not to get into the weeds too much, but its basic mechanism is it interferes with the neurons of these parasites, and causes neuronal dysfunction, and then the parasites essentially die due to severe dysfunction of their nervous systems. And that's why, like, if you take too much ivermectin, you overdose, it can have neurological side effects. Now, in typical doses, right, standard doses, it's actually pretty safe. It's actually a very safe medication for the most part. But how that translates to effectiveness for COVID-19, like as an antiviral, I don't know. I haven't really seen anybody propose some mechanism by which this would work. There are a lot of people that think it works, and there are a lot of people that swear by it. But here's the thing: when it comes to these viral infections, even COVID-19, what happens to most people that get COVID-19? Most people, let me ask that question. What's going to happen most of the time if you get infected with COVID-19 or with SARS CoV-2? What's going to happen most of the time?
You get over it.
You get over it, right? Now, in some people, up to 20% of people that get it, they're going to have more problems. They may need some oxygen. They may have some like long COVID, right? So 20% of people, which is much higher than influenza, right? With influenza, far less than 20% of people that get flu go on to have all these other problems, right? So COVID-19 is much worse than flu. It's like an order of magnitude worse than flu, but 80% of the time you get COVID, more or less, you're good to go, particularly if you're a fairly young, healthy person who's immunocompetent, right? You get over it, no big deal, right? It's kind of like the flu at that point. But 20% of people go on to have these problems. So 80% of the time you get better, right? So the problem with figuring out if something is effective or not is, well, how do you know it was the ivermectin that you took, right? But how do you tease that out? Like I drink this BioSteel stuff here. It has electrolytes. It keeps me from vapor locking after I work out. My muscles don't seize up. Let's say that I get COVID-19 and every day I drink one of these. It'd be very easy for me to say, oh, I got better because of BioSteel, right? Well, is that possible that BioSteel has antiviral action? Maybe, right? But how do I tease that out from all the other drugs that I might be taking, or just the fact that I just got better? So when it comes to things like ivermectin and hydroxychloroquine and that, what you really need to do is you need to do a large randomized controlled trial, right? And you give an intervention and you give placebos and you control, right, what people get, right? So you don't have some person, right, that's taking hundreds of other drugs and getting all these other therapies. You really control and you try to focus in on just like one therapy to see if that has any benefit, and you look for a signal. And in the absence of that, it's just like all guessing, I don't know, maybe it does. And that's where we're at with a lot of these. Now, there are large randomized controlled trials going on right now that are specifically looking at ivermectin. I haven't seen any preliminary data out on that, but they're going on, and we should, within the next few weeks to maybe months, have some answers, some more definitive answers when it comes to ivermectin. But right now, all I can say is I don't know. There's no evidence. There's no real good evidence that I'm aware of. All the evidence is like really small patient numbers. There was like this smoking gun trial out of Egypt that just showed a super strong signal that, yep, ivermectin really helps. And then we have since found out that those people plagiarized. They made a lot of crap up, and they literally like copy and pasted stuff into the paper that they published. And so it was actually retracted about a month or so ago because so much of that data just appeared completely fabricated and copied and pasted and whatnot. And so there's just no evidence. So I wish I had a better answer for you all, but that's medicine. It's messy. It's definitely very messy. Yeah, no problem. Yeah.